Okay. Sorry, the mic was off. Sorry. I think now it is audible. It is audible now. Please reply. Yes. Okay. Thank you. So again, we'll start this question that what will happen that most of the time what will happen that you have such kind of clinical scenario based question from this topic. Now in this, what is the important thing is that when you will go through the question, you have 2-3 important lines like there is a abnormal large baby which is of 4800 grams. What is the weight of the baby? 4800 grams. Now normally you will have a baby which is between 2.5 to 3 kg, but this is 4800 grams baby, and because of the larger size of the baby, when the obstetrician is trying to deliver vaginally, this baby is get stuck. And why there is a stuck? Because the shoulders are broad and it is having a abnormal, or you can say larger size of the baby is there. Now to deliver such baby vaginally, the doctor is doing some manipulation, and such manipulations are going to harm the baby. Now what are the harms that we are going to discuss? And that is actually the injury in the brachial plexus. So whenever you have such question where you will find that the baby is stuck behind the maternal pubic symphysis and doctor is trying to pull out the baby, there are very high chances in the brachial plexus injuries, and you have such 2-3 questions below the this clinical scenario that what is the most likely diagnosis, what is the most likely etiology, and what is the anatomical mechanism for this disorder. Clear? So we'll discuss all these 3 questions one by one. So let's first start with the introduction of brachial plexus. So whenever we are talking about the brachial plexus, the first thing should be very clear in your mind that brachial plexus is a plexus which is supplying to the upper limb. So whenever we are talking about the nerve supply, it is actually the supply of upper limb, that is the brachial plexus. This brachial plexus is situated into the axilla and it is entering into the axilla from the neck. So from the neck we are having the nerve roots. These roots are going to form the plexus. That plexus will passes behind the clavicle and then it will enter into the axilla. So in this diagram you can see that this is the site of the formation of the plexus in the neck. Then this is your clavicle. So the plexus is passing behind the clavicle and gradually it is converting, or it is giving the different branches which are entering into the upper limb. Clear? So now students, what is the formation? What are the components? So whenever you are having the brachial plexus, the first and important thing is that Haya Noor is saying, sir, no sound. I think right now it is clear. Are you able to hear me? Still there is no sound, Haya Noor? I think the sound is there now. Earlier the mic was off. Okay, so what is the mode? How the brachial plexus form? What are the components? So when you will see the components means that what are the different parts of the brachial plexus. So there are 5 parts, and these 5 parts are starts from the root. So first there is a root of the brachial plexus, then you will have trunk of the brachial plexus, then you will have divisions of the brachial plexus, then cords of the brachial plexus, and lastly the branches of brachial plexus. Now my dear students, there are 2 things which should be very clear in your mind. One is root of spinal nerve, second is root of brachial plexus. Because I have seen this, that most of the students are having this confusion. Sir, root of spinal nerve is the same for the root of brachial plexus? I am saying, see, I am not using the root of spinal nerve. I am saying root of the brachial plexus. Now, when you will see a classical nerve, now see, try to understand the difference between these 2 lines. when you will see a classical spinal nerve, now here you can see that this is the spinal nerve. Clear? Now this spinal nerve is formed by the two roots. Now spinal nerve itself is having two roots. One is the posterior or dorsal root. Another is its ventral root. Clear? Try to understand this concept that when we are talking about the roots of spinal nerve is formed by two roots. One is the dorsal root. Now in the dorsal root you will have a dilatation is known as dorsal root ganglia, and you will have a ventral root which is motor in characteristic. Now both these roots are joining together and they are forming a nerve which is known as spinal nerve. Now this spinal nerve is further divided into the two division. One is a smaller division is known as dorsal division, and one is a larger division going on the anterior aspect of the body is known as ventral division. Now this ventral division is known as ventral primary rami. This ventral division is known as ventral primary rami. Now students, this is one nerve. Clear? Now there is a one more nerve which is also giving a ventral primary rami. There is a one more nerve which is also giving ventral primary rami. So these ventral primary rami are going to form root of brachial plexus. Clear? So root of brachial plexus is ventral primary rami, or you can say ventral division of spinal nerve. It is not root of spinal nerve. Root of spinal nerve is something which is having a connection with the spinal cord. It is not having connection directly with the spinal cord. Clear? So this should be clear in your mind that whenever we are using the word root of brachial plexus, I am talking about ventral primary rami. Now, how many ventral primary rami or how many spinal nerve involved in the brachial plexus? Answer is C5, C6, C7, C8, T1. So there are 5 nerves which are involving in the formation of brachial plexus. Now what will happen? These roots are going to form the 3 trunks. Now these trunks are arranged in above below direction. So they are known as superior trunk, they are known as middle trunk and inferior trunk. So there are upper trunk, middle trunk and lower trunk. Now every trunk then further divide into the ventral and dorsal or anterior or posterior division. So every division, every trunk is having 2 division, anterior and posterior. Now these divisions will join to each other and they are going to form 3 cords, and these cords are named with the reference of second part of axillary artery, and they are known as medial cord, lateral cord and posterior cord. And finally the cords will divide into the different branches. So what are the components or the parts of brachial plexus? Root, trunk, divisions, cords and branches. So these are the important components whenever you are writing in your exam. Now next, what is the type of brachial plexus? So brachial plexus, basically some book says that these are the types, some book says that there may be the variation in the roots of brachial plexus. So C5, C6, C7, C8 and T1, these are the constant components, plus if there is a C4 also add. So this is C5, C6, C7, C8, T1, but if there is a add-on C4 is there, then it is known as prefixed brachial plexus. But instead of having C4, if there is a add-on on the T2 from lower side, then it is known as post-fixed brachial plexus. So it is, some book says it is a type, some book says there may be a variation. Rather than having 1, 2, 3, 4, 5, it may have 6 roots, and the 6th root may be C4 or T2. Clear? Now, what is the root of brachial plexus, which I just explained, that whenever we are talking about the root of brachial plexus, you should have one word in your mind, that it is ventral rami or ventral division of spinal nerve. Clear? Now, how the trunks will form? What are the trunks of the brachial plexus? So I told you that there are three trunks from above downward: upper trunk, middle trunk, and lower trunk. Now, what are the root value of these trunks? So, dear student, upper trunk is formed by the joining of C5, C6 root. Middle trunk is continuation of C7 root, and lower trunk is formed by the C8, T1 root. Now, in this image, you can appreciate this thing that this is C5 and C6. Both are joining together and they are creating a one cord. This is trunk, which is known as upper trunk. The lower two, C8, T1, joining together and they are forming a one more trunk, which is known as lower trunk. And the C7 continue as a middle trunk. Clear? So upper two will join, lower two will join, middle will continue itself. So what is the root value of upper trunk? Upper trunk is formed by C5, C6. What is the root value of lower trunk? C8, T1. And what is the root value of middle one? Is C7. Clear? Now, dear students, what will happen that every trunk is further divided into the anterior or ventral and posterior or dorsal division. So what will happen that each trunk will divide. So here you can see that this trunk is split here. So this is anterior and posterior, anterior and posterior, anterior and posterior. So every trunk will split into the two division, anterior division and posterior division. Now, trunk divide into the lower part of the neck. This is the important thing. And retroclavicular part. Retroclavicular part means that when you are doing the dissection, and if in the dissection you are trying to adjust this whole structure, you have to understand that root and trunk will lies above the clavicle. And as soon as you will approach towards the clavicle, this trunk has already been divided into the two divisions. Clear? So now what will happen that cords is forming. Now these cords are lateral cord, medial cord and posterior cord. Now how they will form? Now for that I will just explain you first how to draw. Now if you will have this idea how to draw, the previous three slides become easy. So let's draw with me how to draw the brachial plexus. It is a very simple line diagram. So first I will draw 5 arrows, 5 lines. These 5 lines are representing C5, C6, C7, C8 and T1 root of brachial plexus. So initially I have made 5 lines which are 5 ventral rami, or you can say roots of brachial plexus. So we'll label here roots. Clear? Then what will happen next is trunk. So how the trunk will form? C5 join with the C6 and there is a formation of a trunk. C8 join with the T1, it is going to form a trunk, and the C7 will continue itself. So now what is the next step? These are the 3 trunks. These are the 3 trunks. Upper trunk, lower trunk, middle trunk. Clear? Now what is next? Now every trunk further divided into the 2 division. Every trunk further divided into the 2 division. So these are the next part is division. Clear? So roots. So first we have seen the roots, then trunks and then divisions. Now suppose this is anterior division, this is anterior division, this is anterior division, this is posterior division, posterior division, posterior division. Clear? Now what next is we are going to form cords. Now what next is we are going to form cords. Now how many cords? 3 cords: lateral cord, medial cord and posterior cord. Now dear students, First, always draw the posterior cord. So posterior cord is formed by the joining of all the three posterior divisions. So this is the first posterior division, this is the second posterior division, and this is the third posterior division. All the three posterior divisions join together and they are going to form a cord, and that cord is known as posterior cord. Clear? So I will give you one concept that posterior cord is formed by dorsal or posterior divisions of all the three trunks. Try to understand this concept. Posterior cord formed by all the three posterior or dorsal divisions of all the three trunks. And dear students, if you will see the branches of posterior cord, they will supply dorsal surface of upper limb. Clear? Dorsal surface of upper limb. For example, if you will see the radial nerve is a branch of posterior cord, and radial nerve is a nerve of the back of the upper limb. It will never come on the front. So in this way you can remember that dorsal surface of your upper limb, the muscles of the dorsal side, supplied by the posterior cord, which is formed by the dorsal divisions of three trunk. Now, how there is a formation of lateral cord? So this anterior division of upper trunk and this anterior division of middle trunk, they both will join and they are going to form lateral cord. So this is a lateral cord, this is the posterior cord. Now here you can see there is a one division is left. Now this single division will continue as a medial cord. This will continue as a medial cord. So this will become medial cord. Clear? Again, try to understand this concept. There are 5 roots, C5, 6, 7, 8, T1. Initially, you have to make 5 roots. Then you have to join C5 and C6 to form the upper trunk, C8 and T1 to form the lower trunk, and C7 continue as a middle trunk. Then what will happen that every trunk will divide into the anterior, posterior, anterior, posterior, anterior, posterior division. Posterior division of all the three areas will join to form the posterior cord, and anteriorly these two will join lateral cord, and this anterior division of lower trunk continue as a medial cord. Now, dear students, you can apply a little bit mathematics here. What is the root value of lateral cord? Now this is the question. What is the root value of lateral cord? My answer is C5, C6 and C7. If you want to check, you can go in a reverse direction. This is the one division. This division is coming from C5 and C6. So C5 and C6 both are contributing in the lateral cord. Now this is the C7. Now this C7 is also contributing in the lateral cord. So what is the root value of lateral cord? C5, C6, C7. What is the root value of medial cord? Answer is C8 and T1. If you will track it again in the reverse direction, you will find that it is having C8 and T1. But if you will see the root value of posterior cord, it is having all the components C5, C6, C7, C8 and T1. That you can appreciate here, that posterior division of this, posterior division of this, posterior division of this, they all are coming from these all roots. Clear? Now, why I am saying this? Because this is helpful always in understanding the diseases. It is always helpful to understanding the area supplied by these different cords. So, if you will have this idea how to draw the brachial plexus, it will become easy to understand the anatomy of the brachial plexus. So brachial plexus, if you will see that when we are talking about the cords, so what is the lateral cord? Lateral cord is formed by the union of ventral division of upper trunk and middle trunk. Medial cord is a continuation of the ventral division of lower trunk, and posterior division is formed by the union of all the dorsal divisions of three trunks. Clear? So this is the important concept. I hope it is clear to everyone. If anyone is having question, you can ask me. Farhan, thank you. Creative Chora. Aji, Hayanur, Harish, anyone. If you are having any question, you can please ask. Mustafa. Okay. So now we'll move to the next part, is relation of the chords. Now, dear students, relations of the chords again is a conceptual thing which I told you in the class of axilla also, that what will happen here, if you will see in the neck, now this is your neck, suppose this is your neck, what is happening, that artery is coming out from the heart and it is going into the upper limb like this. So what is the source of artery? It is coming from below, then it is making an arch, and then it will enter into the upper limb. But when you will see the source of the nerves, now they are coming from the cervical region, C5, C6, C7, something like this. So what you are able to understand, that initially the brachial plexus formation is superior to the artery. The formation of brachial plexus is superior to the artery. So in this image you can see that these are the three cords which lie superior to the artery. And gradually what will happen, that these cords will come in the relation of the second part of axillary artery. So dear students, in these two diagrams, I already explained these diagrams in the class of axilla, that what is happening, that when we are talking about the first part of the axillary artery, which is before the pectoralis minor muscle, we realized that the medial cord lies behind the artery. Medial cord lies behind the artery. Why behind the artery? Because it is gradually crossing the artery from above downward to approach medial side of the artery. So in this diagram you can see that this is the medial cord. This medial cord has to come here on the medial side. Now to approach or to come on the medial side of the artery, it is having two options. Either it can come from front of the artery, or it can take the course behind the artery. So here you are able to understand that it is passing from behind the artery. That's why the medial cord is behind the first part of the artery. But in the second part of the artery, you will realize that all the three cords come in their relative relations. Now the medial cord comes medially, the lateral cord comes laterally, and posterior cord comes posterior to the second part of axillary artery. Clear? So I hope till now the things are very clear to you. Now for the purpose of your study, for the purpose of your exam, you have the two sets of the question. Write down supraclavicular part of brachial plexus, because brachial plexus is a very huge topic. Or you may have the question, write down infraclavicular part of the brachial plexus. So dear students, when we are talking about supraclavicular, you generally have the roots and trunk, and divisions will go behind the clavicle or retroclavicle, and the cords are present in the infraclavicular part. So infraclavicular part of the brachial plexus generally involve the cords and their branches. Now we'll talk about the branches. Now branches will come from the roots, they will come from the trunk and the cords. Division will not give any branch. So when we are talking about the branches of the roots, there are four important branches. The first branch is known as long thoracic nerve. Now see, these are the roots. So one is coming from the C5, C6, C7, C8, and they are going to form a nerve, and this nerve is known as long thoracic nerve. So long thoracic nerve is C5, C6, C7, sometimes C8, and this long thoracic nerve is going to supply serratus anterior. So root value is C5, C6, C7, and what is the muscle supplied by long thoracic? Serratus anterior. Now, injury of serratus anterior will lead to the winging of scapula. So, this is a question for your exam, that nerve to serratus anterior arises from, answer is, roots of brachial plexus. Second branch is dorsal scapular nerve, which is a branch of C5. Now, this dorsal scapular nerve, which arises from the C5, is going to supply our rhomboidus major and minor muscle, which are arises or which are present along the medial border of the scapula. So, dorsal scapular nerve supply which muscles? Answer is rhomboidus major and minor. It comes from, answer is, C5 root, and it supply rhomboidus major minor muscle. Now there is one more important thing, dear students. When you will see the dissection, you will realize that this rhomboidus major and minor nerve, that means the dorsal scapular nerve, approaches to these muscles by piercing the scalenus medius muscle. This is a question which has been asked so many times, that which nerve pierces scalenus medius? Answer is dorsal scapular nerve. Now there is one more nerve is here, is the phrenic nerve. Phrenic nerve basically coming from C3, C4 and C5. What is the root value of phrenic nerve? C3, C4, C5. Because we are reading only the brachial plexus, which is from C5 onwards. So that's why we are taking only C5. Otherwise, phrenic nerve is formed by three roots, C3, C4, C5. C5 roots is from the brachial plexus. And phrenic nerve supplies diaphragm. Then we'll have one more nerve from the root, and this is going to supply your longus colli. Now, what is longus colli? Now, this is a very deep anteriorly placed paravertebral muscle. Now, here you can see these are the longitudinal muscles, and these longitudinal muscles are known as longus colli. So, these longus colli are supplied by the branches of the roots of brachial plexus, which is C5, 6, 7, 8. Clear? So, what are the branches of roots? So, first branch is nerve to serratus anterior. Second is dorsal scapular. Third is phrenic nerve, and fourth is branches to the longus colli and scalenia. Now we'll move to the branches of the trunk. Now there are three trunks from above downward: upper trunk, middle trunk, and lower trunk. Out of these three trunks, only the upper trunk will give branch. Now here you can see this is your upper trunk, this is your middle trunk, and this is your lower trunk. But when we are talking about the branches comes only from upper trunk. And how many branches? There are two branches. One is going to the subclavius muscle, is known as nerve to subclavius, and one is going towards the suprascapular notch, is known as suprascapular nerve. And dear students, the upper trunk comes from the C5, C6. So the root value of both these nerves is C5, C6. Clear? So what is the nerve supply of subclavius, nerve to subclavius? It is a branch of, answer is, it is a branch of upper trunk. Now see, the question is not about the subclavius, question is about the joint. The sternoclavicular joint is supplied by which nerve? Answer is nerve to subclavius. The suprascapular nerve will go towards the suprascapular notch, where you will have a ligament is known as transverse ligament, and it is going to supply supraspinatus and infraspinatus. Now I will tell you here. Now this is the scapula, which you know. Now on the superior border of the scapula, you are having a U-shaped notch. Dear students, this notch is known as suprascapular notch. Now there is a ligament. Now this ligament is known as transverse scapular ligament. This is known as transverse scapular ligament. Below this ligament, here you will have a nerve, and that nerve is known as suprascapular nerve, which is a branch of upper trunk. This suprascapular nerve is going to supply supraspinatus and infraspinatus muscle. Now, dear student, this is very commonly asked question. Try to understand this question, that what will happen, that we are going to cut the phrenic nerve. So sometimes after crushing the phrenic nerve in the neck, it does not cause paralysis of diaphragm on that side. If I am cutting the phrenic nerve on the right side, my right diaphragm should be paralyzed because phrenic nerve is the nerve supply of diaphragm. But even though I am cutting the phrenic nerve, still the right side diaphragm is not paralyzed. Why? If it is happening, then always think about the presence of accessory phrenic nerve. Always think about accessory phrenic nerve. So, if there is no loss of the contraction on the ipsilateral half of the diaphragm after cutting off that side of phrenic nerve, we have to think about the accessory phrenic nerve of that side. So, what is happening here? Sometimes the C5 fibers through the nerve to subclavius join the phrenic nerve, and this contribution is known as accessory phrenic nerve. So due to the presence of accessory phrenic nerve, still the contractions in the diaphragm are present. Clear? So I will again explain it. So this is the C3, C4 and C5 which are giving the phrenic nerve. So this is the phrenic nerve. Clear? So this is the phrenic nerve. Now what you did, you cut it here. You have cut it here, and once you will cut it, now the diaphragm of this side should be paralyzed. But what is happening? Why this diaphragm is not completely paralyzed? Because this C5 is contributing, this is giving nerve to subclavius. Now this nerve to subclavius is giving a one branch, and that branch is going to the diaphragm. This branch is known as accessory phrenic nerve. So accessory phrenic nerve is a branch of nerve to subclavius. And this is the important thing, that sometimes this nerve to subclavius, which is a branch of upper trunk, is, if present, will contribute in the nerve supply of diaphragm. Clear? So this is the question. This is a theoretical question. Clear? And if this type of theoretical question is there, you always keep in mind that after cutting the phrenic nerve, if still the diaphragm is contracting, that means we are talking about accessory phrenic nerve. Now we'll talk about the branches of cords. So there are three cords: lateral cord, medial cord and posterior cord. Lateral cord give three branches. What are the name? These are known as LML. LML means lateral pectoral nerve, lateral root of median nerve, and M stand for musculocutaneous nerve. Now all the three arises from lateral cord, which is having the root value of C5, C6, C7. Now here the question comes is that how to identify the musculocutaneous nerve in the dissection. So musculocutaneous nerve is the lateralmost nerve, and when it is going laterally, it is going to pierce a muscle here is known as coracobrachialis. So this is the important question, that which nerve pierces the coracobrachialis? Answer is musculocutaneous, or vice versa, musculocutaneous pierces which muscle? Answer is coracobrachialis. Now what are the branches of medial cord? Dear student, medial cord give 5 branches. Now what are these 5 branches? Medial pectoral nerve, medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, medial root of median nerve and ulnar nerve. So medial pectoral nerve, again it is a nerve which is going to pierce the pectoralis minor. Now till this slide, I told you 3 nerves piercing the 3 muscles. I just saying this again and again, that these are the some important question. Sometimes what will happen in Viva, you examiner asks, tell me the nerves of the upper limb which pierces the muscle. Clear? So examples are, one is dorsal scapular nerve that pierces scalenus medius. Just like I told you, the musculocutaneous nerve which pierces the coracobrachialis muscle. Here is one more example, medial pectoral nerve which pierces the pectoralis minor muscle. Clear? Now medial cutaneous nerve of the arm, forearm, medial root of median nerve. So median nerve is formed by the 2 roots, lateral root and medial root. Lateral root comes from the lateral cord, medial root comes from the medial cord. And then the ulnar nerve. Ulnar nerve is one of the very thick nerve, and it lies deep to the medial cutaneous nerve of the forearm in area between the artery and vein. So dear students, this is again a question for your Viva, that this is a gap. Here you can see the area. This area is between the 2 structure. What these 2 structure? This is your artery, this is your vein. Now question comes is that which structure lies in this area between the artery and vein? In this area, I just make it black. Now question is that in this black area, name the nerves. Answer is medial cutaneous nerve, the forearm and ulnar nerve. Please try to understand that I am talking about just inside the third part of axillary artery. So there are two structures. What these structures are? Ulnar nerve and medial cutaneous nerve of forearm. Clear? Now, what are the branches of posterior cord? There is a mnemonic for that, and that is ultra. Now, what do you mean by the ultra? Now, U for upper subscapular nerve, L for lower subscapular nerve, T for thoracodorsal nerve, R for radial nerve, and A for axillary nerve. Now, this upper and lower subscapular nerve. Now, this upper and lower subscapular nerve are going to supply subscapularis muscle. Upper and lower subscapular nerves are going to supply subscapularis, but this lower scapular additionally supply a muscle is known as teres major. It is supply teres major. Now this is a thoracodorsal nerve which is supply latissimus dorsi. Now the question comes is name the nerves which is supplying the muscles inserting on bicipital groove. Name the nerves which are supplying the muscles inserting on bicipital groove. So bicipital groove or intertubercular groove is having three muscles ready between two major. Pectoralis major on the lateral lip, teres major on the medial lip, and latissimus dorsi in the floor. So what is the nerve supply? So pectoralis major is supplied by medial and lateral pectoral nerve. Teres major is supplied by lower subscapular nerve, and latissimus dorsi is supplied by thoracodorsal nerve. So such kind of questions are present in your exam. Then radial nerve and the axillary nerve. Radial nerve is the thickest nerve of the posterior cord, which will go on the back of the arm, and then you will have the axillary nerve. So in nutshell, if you will see the branches, so branches comes from the root, trunk, from the trunk, only upper trunk, and the cords. Clear? So that is the important thing about the brachial plexus. Now we'll move to the applied anatomy. Till here, if you have any question, you can ask. One student is saying, sir, you will one day be rewarded for your efforts. Thank you. One is saying, Vande Mataram, Vande Mataram. So till now, if you will have any question, you can ask. Otherwise, we'll move to the next part of the class is the brachial plexus injury, which is more concerned with the Orb's paralysis and Klumpke's palsy, which are the two very important questions from this topic. So let's start with the introduction of brachial plexus injury. Now, whenever we are talking about the brachial plexus injury, these injuries can be occur in the root of the brachial plexus, trunk of the brachial plexus, division, cords, or the branches. Anywhere in any 5 parts, you may have the injury. Now, when we are talking about the supraclavicular, when you are talking about the injury above the clavicle, then we are talking about the injuries in the roots and the trunks. But when we are talking about the below clavicle injuries, that means infraclavicular, then we are talking about the mainly injuries in the cords and the divisions. Clear? So supraclavicular roots and trunks, and infraclavicular divisions and cords. Now, what could be the most common causes of the injury? The injury can be occur because of the compression of the nerves. The injury can be occur because of the excessive traction or the stretching of the nerves, or it can be occur if there is some sharp wounds are there due to some stab knife wounds. Clear? So these are the some common causes of the injuries in brachial plexus. So let's discuss these injuries. One is known as Orb's paralysis or Orb's palsy, which is one of the most important question throughout the globe. In every part of the world, you have such questions in your exam. Now, what do you mean by the Orb's palsy? Orb's palsy is caused by the injury in the upper trunk of the brachial plexus. See, how many trunks are there? 3 trunks, upper, middle and lower trunk. But when there is an injury occur in the upper trunk, it is known as Orb's paralysis. Now this name comes after the name of Wilhelm Heinrich Orb. Now this is a German neurologist. Now this fellow gives this name Orb's palsy. Now what do you mean by Orb? Now Orb means it is a meeting point of 6 nerves. Our point means there is a meeting point of 6 nerve, and these 6 nerves are meeting in the upper trunk. Now here in this image you can see that this is our two roots, C5 and C6. These two roots are joining the upper trunk, and upper trunk is dividing into the anterior and posterior division. So there are 4 nerves, 2 are coming from back, 2 are going from the trunk. So bifurcation is there and meeting of there. Now this upper trunk is giving additionally the 2 branches, nerve 2 subclavius and suprascapular nerve. So ultimately there are 6 nerves which are having this area, and this area of the upper trunk is known as Orb's point. So what is Orb's point? Orb's point is defined as a point of the upper trunk where the 6 nerves are meeting. Now what are these 6 nerves? Root C5, root C6, then anterior and posterior division of upper trunk, and nerve 2 subclavius and suprascapular nerve. So these are the 6 nerves. So when there is an injury occur in the upper trunk, which nerve roots will involve? C5 and C6. So Orb's paralysis is basically involving the injury of the C5 and C6 root. So the muscles which are supplied by the C5, C6 will get affected. So what is the cause of Orb's palsy? Now the cause of Orb's palsy is when any condition which is creating traction on the upper cord. Now see, suppose this is the area of my neck and the shoulder, between the neck and shoulder, where you will have the upper trunk. Upper trunk is the most superficial because it is upper. Then you will have middle, and then you will have lower. So lower is the deeper, upper is the superficial. Now if you are touching your ear to this side of shoulder, the upper trunk will not get a stretch. Clear? Rather than it will get relaxed because the distance is decreasing. But if I am doing overstretching of this area, if I am overstretching this distance between the ear and the shoulder, the distance will increase. And if I will increase this distance forcefully, what will happen? The upper trunk will have excessive strain because of the forceful stretching of this part. So upper trunk will get injured when there is a overstretching in an area between the shoulder and this neck area. So here in this image you can see that what is happening, that this is a baby of excessive weight, and the doctor trying to deliver this baby vaginally, and what will happen that because it is not having a normal descent, the doctor is putting some maneuver, and in such maneuver he is pulling the face, he is pulling the neck. So once he is pulling the neck, he is folding the neck in upward direction. Now what is happening? Now see, there is a stretching occur here. The distance on this side decreases, but the distance on this side increases. So because of the excessive pulling, if somebody will pull my head like this area is having the stretching. And this stretching will lead to the injury into the upper trunk. In the same way, if a person fall from the height, and if I will fall on this part touches first to the ground, there is an excessive stretching occurs, and this is again going to do excessive traction or stretching of your upper trunk. So for the injury of upper trunk, what you need the excessive stretching, and this stretching is provided when the distance between the shoulder and the neck will increase. So increasing distance is a cause of upper trunk injury. So here you can see that due to the stretching or the traction, there is an injury in the upper trunk which is caused by pulling away the head from the shoulder. Pulling away, you are pulling away the head from the shoulder. So you are increasing the distance. Second thing is that what will happen, an adult fall on the shoulder. If an adult fall on the shoulder. Clear? So when you are pull out the head, when you are stretching the head, you are not stretching the limb. You are not pulling the limb, you are pulling the head. So when you are pulling the head, there is a high chances of upper trunk injury or Erb's palsy. Clear? Now, what are the nerves which are having component of C5, C6? So C5, C6 means there is involvement of axillary nerve, there is involvement of musculocutaneous nerve, there is involvement of subclavius nerve, suprascapular nerve, and partial involvement of radial nerve. So nerves which are having C5, C6 component will definitely affected in this injury. Clear? So what are the nerves which are affected? Axillary nerve, musculocutaneous nerve, nerve to subclavius, suprascapular, and part of the radial nerve. Now here you have to understand that axillary nerve supply the your deltoid muscle, and your suprascapular nerve supply the supraspinatus. Suprascapular nerve supply supraspinatus. So you know that supraspinatus is a initiator of abduction, and deltoid is also helpful in the abduction. But because these both muscles are paralyzed, so that baby is not able to do the abduction, that person is not able to do the abduction. Clear? So there is a long list of the muscles which are involved in this disease, in this problem. So deltoid is affected, biceps is affected. Why biceps? Because there is involvement of musculocutaneous. So patient is not able to do the flexion. Then brachialis is involved because it is also supplied by the musculocutaneous. Clear? There is involvement of brachioradialis. Some fibers of radial nerve is also affected. Then supinator is also paralyzed. Then supraspinatus and infraspinatus, which are supplied by the nerve to suprascapular. So what is happening? Now because I am not do the abduction, my upper limb is remain hang by the side of the body. Clear? Then I am not able to do the lateral rotation, so my limb is remain internally rotated. And I am not able to do the flexion, so it is remain extended. So my limb remain like this, and this is the position of your upper limb, which is known as what? Hanging by the side. But it is known as policeman tip deformity. It is known as policeman tip deformity. Now why it is known as policeman tip or policeman hand deformity? Because students, you have to understand this thing, that the finger movements are normal. This is the important concept to understand, that in Erb's paralysis, the movements of the finger never lose, because these are the small fingers which are supplied by the C8T1 root. Please keep this thing in mind, that in Erb's paralysis, the finger movements never lost, finger movement are always persist. So what will happen, that when you will have this kind of the position, you can hold something from back, just like you are giving bribe to the someone and he just put it inside the pocket. So this porter tip deformity or policeman tip deformity is there. It means that when you are offering some money or you are offering some tip to the person, he is having the movement of the finger to hold the same thing. Clear? So that's why this is the important thing. So what are the things involved in the Erb's palsy? There is a loss of abduction. Why there is a loss of abduction at shoulder? Because of the involvement of supraspinatus and deltoid. There is a loss of the lateral rotation at the shoulder joint because of the involvement of teres minor and infraspinatus. There is a loss of biceps jerk. There is a loss of flexion because of the involvement of biceps and brachialis. There is a loss of supination because of the involvement of supinator. Plus, there is a loss of the sensation in the small area of the deltoid, and this is known as regiment badge sign. This is known as regiment badge sign because of the injury of axillary nerve, because of the involvement of axillary nerve. So, dear students, whenever you are having this question on the Erb's palsy, I hope now you are having the idea that Erb's palsy means there is an injury of Erb's point, which is a meeting point of the six nerves. These six nerves are present in the upper trunk, and whenever the injury is there, the most common cause is overstretching in this area between the neck and the shoulder. And this overstretching occurs during birth injury or if a person fall directly on the shoulder. And in such cases, what is happening? The most important thing is that your hand is remain by the side of body, but the finger movements are persist. I am repeating this again and again that finger movements are normal in the Orb's palsy. But dear student, now the challenge comes that how to check the newborn. Because this is a common question in your exam that a small baby bring to you, and if I will give a baby who is 2 or 3 days old, how will you identify that that baby is having the Orb's palsy? So the first thing is by the position of upper limb. You will find that the baby will come in such position. Now the second thing is that we will do the two reflexes of the newborn. One is known as grasp reflex. Now what will happen as soon as you will place something in the hand of the baby automatically the finger will close. That is a normal reflex generated by the baby. So that is a normal response that if I will place something in the hand of the baby will hold this. So that is the one thing. So grasp reflex is showing that the finger movements are normal. Second is the Morose reflex. Now what is Morose reflex? Now this is the Morose reflex. Now in this what will happen? You just hold the baby and just there is a free fall for the few height. For a small height you just leave it. Clear? And for these 10 centimeter height, as soon as there is a free fall of the baby, there is a reflex that baby will do like this. Now what is that? This is abduction, there is a external rotation, there is a extension, and this is the Morose reflex. But if this side of limb is paralyzed, the baby will do like this. This limb is not moving. So this is a very important thing to understand. This is a very commonly asked question in your exam, that a adult person is having the ability to explain his deformity, but a newborn is not able to explain its disability. Then how will you examine? So you will examine with the help of Morose reflex. So if the baby is not able to do the abduction, that means he is having a chance of Orb's paralysis. Clear? Now we'll move to the Klumpke's paralysis. Now the Klumpke's paralysis is the injury in the lower cord, and when you will see the Klumpke's paralysis, the lower trunk of the brachial plexus causing paralysis of hand muscle. So now this is the important thing, that in Klumpke's paralysis the hand movement is not there. Please try to understand what is the basic difference between the Klumpke's and Orb's. That in the Orb's palsy you will have injury in the upper trunk, but the finger movements are normal. In Klumpke's palsy you are having injury into the lower trunk. You are having injury into the lower trunk, but along with that the hand muscle movements are affected. So what is the site of injury in the Klumpke's palsy? Is the lower trunk, and lower trunk is root value C8T1. C8T1. But sometimes in MCQ you will have A C8, B T1. If you will have a separate answer, and if you don't have both of them, then always go with T1 mainly. If you have both options C8 and T1, then it's good. If you don't have both options, and if you have C8 or T1, then always try to stick with T1 only. So T1 fibers mainly supply the lumbricals and interossea. So lumbricals and interossea are very short muscles in the hand, and these muscles are responsible for the movement of metacarpophalangeal and interphalangeal joint. So affection of these muscles are responsible for the claw hand. So that is the deformity in the Klumpke's paralysis. Now why their lower trunk will get injured? So if you will see the mode of injury here, these are the two diagrams which are showing the mode of injury. Now this is the lower trunk. So lower trunk is below, upper trunk is superficial. So now something which is hurting from down is going to injure lower trunk, not the upper trunk. Now there is some overstretching occur here. Now what is happening here, that this fellow is having free fall from the tree, and during the free fall suddenly he hold some another branch of the tree, and because of the gravity, as soon as the weight will go down, there is a sudden overstretching occur in this inner side of the axilla, and this is going to damage the lower trunk. It is not going to damage upper trunk because it is here. Clear? So sometimes what will happen, you are having a question which is having history that a person is working in a 10 on the 10th level in a building, and there is a sudden fall, and when the person is falling, during the fall he holds some iron rod, and that's why now this Klumpke's paralysis can occur. So this is the one mode of the injury. Second mode of injury is again the birth injury, but now the doctor is not pulling the head. Rather than pulling the head, you can see that this doctor is pulling the limb. So if a medical person is pulling the limb of a baby to take him out, now when you are doing this position, again you don't have stretch here, you have stretch here. So dear student, there is an excessive abduction of the arm. Clear? So by pulling the arm, so the traction is, there is a pulling of the upper limb excessively to take out the baby during the birth, or when a person fall from a height and may try to catch something in between, is having excessive traction. So dear students, these are the two ways of the injury. If a doctor or a medical professional pulling the head to deliver, there are high chances to injury of the upper trunk because of the stretching of the neck. Here, there is a stretching of the area between the this inner side of the axilla. That is your Klumpke's paralysis. Clear? In the same way, if there is a fall on the shoulder, then there is an injury of the upper trunk. But when there is a vertical fall, then if you hold something in between, then there is a chance of the injury in the inside the arm, that is lower trunk injury or Klumpke's paralysis. So these two modes of the injuries are very important whenever you are reading any question or if you are trying to attempt something. Now, other causes of the lower trunk injuries may be in case of the cancer diseases. When there is a metastasis, the axillary lymph nodes may compress the lower trunk, and there is one very important thing is cervical rib. Now, what is cervical rib? Cervical rib is nothing but it is a extension or fibrous modification of the C7 transverse process. So, when there is a this is a C7 vertebrae. Now, from the C7, what is happening? There is a extension, and this is known as extra rib, which is known as cervical rib. Now, this cervical rib is compresses the nerve which is coming out here. So, here you will have a T1 nerve root. So T1 nerve root sometimes get compressed by the cervical nerve, which could be the one of the reason of the this compression of T1. Clear? Now, which muscles involved in the Klumpke's paralysis? So again, dear students, it is important to understand in your concept that intrinsic muscles of the hand. Now, what is intrinsic muscles of the hand? Lumbricals and interossei. Lumbricals and interossei, and these are basically supplied by ulnar and medial nerve. From which component? T1 component. From T1 component. Clear? So this is the important thing, that whenever we are reading the Klumpke's paralysis, we are talking mainly injury of the small muscles of the hand. But when we are talking about the Au's paralysis, we are talking about the bigger muscles of the hand, upper limb. Clear? And there in the Au's you have C5, C6 root involvement. Here you mainly have involvement of T1 root. So what is the deformity in the Klumpke's paralysis? In Klumpke's paralysis, you will have a claw hand. Now what is claw hand? Now here you can see the claw hand. Now claw hand means, suppose this is my hand, so I am doing hyperextension at metacarpophalangeal joint. So the first component of clawing is hyperextension of metacarpophalangeal joint. Clear? And second thing is flexion of interphalangeal joint. Now this is known as clawing. This is known as claw hand. So claw hand deformity is having two components. First component is hyperextension of metacarpophalangeal joint, and second component is flexion at interphalangeal joint. Now the question comes, why these two deformities are taking place? So normally what is happening, that this hyperextension is avoided. Why avoided? Because the extensor digitorum is unopposed by the lumbricals. You have to remember that our lumbricals and interossei are having two jobs. What is the job? They are causing flexion. They are causing flexion at metacarpophalangeal joint and they are causing extension of IP joint. They are causing extension of IP joint. That means when you are doing this movement, in this movement, what is happening? There is a flexion at metacarpophalangeal joint and there is a extension of IP joint. Now, this movement is possible because of lumbricals and interossei. But what is happening? This flexion of metacarpophalangeal joint is lost. Why? Because your lumbrical and interossei are paralyzed. So, now the unopposed action of extensors is there. So, it will pull your metacarpophalangeal joint posteriorly in the hyperextension. Plus, the extension of interphalangeal joint, that means straightening of the finger is lost. So the unopposed action of the flexor digitorum superficialis and profundus is there, which is responsible for the flexion of interphalangeal joint. Clear? So the flexion of interphalangeal joint is neutralized by the lumbrical and interossei, and hyperextension of metacarpophalangeal joint also neutralized by the lumbricals and interossei. So because lumbricals and interossei are paralyzed, so there is a hyperextension and flexion of IP joint is lead to the clawing hand. So why there is a clawing? Because of the paralysis of lumbricals and interossei. Clear? Now, what are the other deformities which you are able to see in the Klumpkes? One is Horner syndrome. Now, Horner syndrome is one of the very important component. Horner syndrome never seen in the Erb's palsy. Horner syndrome is involvement due to the T1, and T1 is also having the sympathetic fibers, and this sympathetic involvement is the Horner syndrome. Then there is a loss of the cutaneous sensation along the medial border of the arm. Why? Again, because it is having the T1 nerve supply. Clear? And if C8 involved, see, generally we are having the Klumpkes means T1, but if C8 is involved, then the cutaneous sensation along the medial border of the forearm and hand will also lost. So generally we'll have the T1 here, and this T1 is there is a problem here in the medial side of the arm. But if the C8 is involved, then you will have the medial side of the forearm and hand. Clear? So this is the different other associated deformity in the Klumpke's paralysis. So what is Horner syndrome? This is again a question. Horner syndrome is having 5 components. One is ptosis. Ptosis means partial drooping of upper eyelid. Now in the upper eyelid you will have a muscle is known as Mueller's muscle. This Mueller's muscle is having sympathetic innervation, and because of the involvement of T1, which is actually having the sympathetic fibers, is going to draw, there is a partial drooping of the upper eyelid. Then you will have meiosis. Now meiosis occurs because the dilator pupillae, which is responsible for mydriasis, is not working. So there is a meiosis. Then there is a anhidrosis. There is a dryness occurs. Why? Because sympathetic glands, sweat glands are having sympathetic supply, and there is no sympathetic supply. That's why there is a dryness. Then there is an anophthalmos. Anophthalmos means that the patient is having a very small eye. You look the face of the patient, you realize that the eye is reduced in size, but actually it is not actually reduced, but because of the partial ptosis, it looks smaller in size, is known as anophthalmos. And there is a loss of ciliospinal reflex. Now ciliospinal reflex is that when you stimulate the skin on the posterior side of the neck, patient is having stimulation in the pupil. So that is known as skin pupillary reflex or ciliospinal reflex. So these are the 5 components which are seen in the Horner syndrome because of the involvement of sympathetic fibers of T1. Clear? So now in this image you can see this is a normal eye. Now if you will see the normal eye, now here if I will draw this, you will realize that there is a still having area above. Now here there is a ptosis. Clear? So ptosis is there, partial ptosis, because you are not able to open the upper eyelid completely, because the muscle which is present in upper eyelid is known as Mueller's muscle is paralyzed. Clear? So that's why you will have this partial opening of the eye. Now this diagram is showing what is the meaning of the sympathetic fibers, white rami communicans and T1. So what will happen that this is the section of the T1 spinal root where you will have a lateral horn. This lateral horn is a source of sympathetic outflow. The lateral horn is a source of sympathetic outflow. So this is a section at the level of first thoracic segment, T1. Now in this segment, you can see that the preganglionic fibers are coming out from the ventral root, and then they will leave the spinal nerve to enter into the sympathetic chain. And these fibers are known as preganglionic fiber, and this connection is known as white rami communicants. This connection is known as white rami communicants. So when the nerve injury occurs here, if T1 is injured here, if the T1 will cut here, what will happen? These preganglionic fiber is failed to reach into the sympathetic ganglia. And that's why there is a loss of sympathetic supply behind this point. Clear? So what is the reason of Horner syndrome? When there is a injury occurs in the first spinal nerve before this white rami communicans, then what will happen? The area which is supplied by the first thoracic sympathetic area is not now having the sympathetic innervation. Clear? So what is Klumpke's paralysis? Klumpke's paralysis, lower trunk injury, involvement of C8T1. What is the mode of injury? When you are forcefully pulling the upper limb, there is a forceful abduction if there. Now what are the features? Claw hand, loss of sensation along the medial side of the upper limb, and there is a Horner syndrome. And dear students, please keep this thing in mind that in claw hand, what will happen? You are talking about involvement of T1, that means lower trunk. In case of paralysis, the finger movements are normal, and there we are talking about Erb's palsy, that means C5, C6 involvement. Clear? So now this question again comes. We started this lecture from the same question. So now after reading this question, you are able to understand that what is the most likely diagnosis. So it is a Erb's paralysis. Clear? What is the most likely etiology? So etiology is that the patient, the doctor is trying to pull out the head, and because there is a pulling of the head, there is a overstretching occur in the neck, and that will lead to the injury in the upper trunk. And what likely anatomical mechanism of this disorder? So that all are discussed in this lecture. Clear? So I hope it is clear to all of you about the brachial plexus and injuries of brachial plexus. Do you have any query? You can ask me. Rahul is saying hello, hi, hello. Allah Ditta is saying kindly answer me, please sir. What is your question, Allah? Sir, please classes schedule bataएं. Dear student, actually I don't have the fixed schedule. As soon as I have the time from my routine, I come for these classes. So right now I have no schedule. Sorry for that. Spurts of knowledge saying, sir, my anatomy upper limb PCT is coming. So no issue. I have already posted lots of the lectures on my YouTube channel. You can go in the playlist of upper limb where you will find almost the most important topics for your university exam and your PCT. So it's not a big issue. Clear? So if you have any question related to today's class, please ask. Clear? So dear students, I hope now from today onwards, if you will read brachial plexus, if you will read the injuries related to brachial plexus, you are able to understand those questions and you are able to attempt those questions. So this is all for today's session. Thank you. Good night. Bye-bye.